Welcome everyone. On behalf of the Regional Office of the Association of Academic Health Centers for the MENA region at the American University of Beirut, we are delighted to have you all participate in our webinar today that will be looking at how to make your hospital COVID-free. Our guest speaker today is Dr. Ibrahim Janahi from Sidra Medicine, an AAHCI MENA member. Dr. Ibrahim Janahi is the Chair of Medical Education and the Division Chief of Pediatric Pulmonology at Sidra Medicine. His area of clinical expertise includes interventional pulmonology, chronic lung diseases with genetic basis, and rare lung diseases in children. Dr. Janahi is also a professor of clinical pediatrics at Weill Cornell Medicine in Qatar, as well as the former executive director of medical research at Hamad Medical Corporation and the former chairman of the National Permanent Licensing Committee in Qatar. Thank you.
Thank you so much, Ala, for the introduction, and welcome everybody to this webinar. And I hope that we can learn something out of the experience that Sidra Medicine has had during this COVID-19 crisis. So without any further ado, my objectives of today's webinar is to, first of all, I'm going to go quickly over the Qatar health system. So put things in perspective, and a little bit around what is Sidra Medicine. We'll talk a little bit more about the National Command Center for COVID-19 in Qatar. What is the strategic health sector plan for the COVID-19, and then how Sidra succeeded to be a COVID-free institution. Then we're going to go through the pediatric care during the COVID-19 pandemic, and then cases that have COVID-19 positive and they are children, how that is handled in the Qatari system. And then how do we maintain our academic agenda at Sidra, being an academic health system during this crisis, and how Sidra contributed and continues to contribute to the scientific montage of the global effort in fighting COVID-19. And we'll end up with some take-home messages, inshallah. First of all, a quick glance over Qatar health system. All the health system obviously is monitored and overseen by the Ministry of Public Health, as most of the countries are. The Qatar health system, like any other country, can be divided into the public sector, the private sector, and in addition we have the quasi-governmental sector as well. The public sector, which basically takes care of the bulk of the patients' care in Qatar. At the primary level, we have the primary healthcare corporate, which basically oversees all the primary healthcare centers, and now many of them are wellness centers, focused on a different model of primary care center. Instead of just a GP sort of model, now primary care is more of a wellness center and more of a care of patients and anticipatory care, as well as is happening in the primary healthcare system. All the secondary, pretty much, care in the public sector is done by Hamad Medical Corporation. Majority of the tertiary, non-pediatric tertiary care is also taken care of by Hamad Medical Corporation. And the National Home Care Program is also delivered by Hamad Medical Corporation system. Now, Sidra Medicine and Aspetar, these are two state-of-art organizations that are quasi-governmental, meaning they are partially, significantly actually funded by the government, but they are rather independent from the public sector. Qatar Foundation owns Sidra Medicine. Qatar Foundation is, as most of us know, oversees many educational and development sort of institution and research and development and our is the hospital that belongs to Qatar Foundation is Sidra Medicine that I'm speaking on behalf of. Hospital is a hospital that is focused on sports medicine, and it is owned by another quasi-governmental organization that basically focuses on sports and sports medicine. It has an academy for sports, Aspire Academy, and Aspitar is the healthcare facility that belongs to that organization. So overall, this is just a glance over the healthcare system in Qatar. So we understand where are we going from and how Sidra is part of this fabric. What is Sidra Medicine? Sidra Medicine is a women's and children's tertiary hospital that was very recently opened and full-fledged in January 2018. Before then, the outpatient was open for a couple of years, and the research branch of Sidra was functional ahead of the clinical branch. Now, currently, we are the main provider of tertiary care for pediatric population and a significant contributor to the women's health in the country. It is a private organization for public benefit, so we are significantly funded by the government through Qatar Foundation and through the Ministry of Finance, and we are majority fee for service, and we're moving towards fee for service, but there is subsidization from the government for some of the services that we provide. Sidra Medicine was always meant to be the beacon of health, education, and research, and it maintains its vision to that level. It is a very young academic organization, but very well achieved and continues to contribute significantly to the academic agenda of the country and region. Now, for the COVID-19 crisis, the government of Qatar put together, as many other countries in the region and the world, a national command center. And it's very critical to have a national command center that would basically manage all the activities in relation to this crisis. So the National Command Center is led by the Prime Minister and is and the Minister of Health, but also is the members of the Supreme Council for Crisis Management, includes representation from the Ministry of Interior, and Ministry of Finance, Ministry of Trade and Commerce, and all the stakeholders, and obviously the Ministry of Health and its subsidiaries. And now the Supreme Council or the National Command Center have been very active in basically putting the plans, the whole management of this crisis together from the different aspects, all aspects, and they managed it top and bottom. They managed the public, they managed the financial and the economic impact, they managed the health impact, and they also managed the media and the public education piece. And as we can see, they always have regular briefings that they share it with the public. They also created a hotline, and this is a hotline right there, where the hotline deals with anything related to COVID-19, from health. Any question related to COVID-19 will be received by this hotline, and they have a very good number of trained personnel who would basically are trained on answering most of the questions that are related to COVID-19 crisis, be it a health issue or an economic issue or an advice, and they have the ability to direct the questions to the right authority if they have further questions. In addition to that, there has been an intense public education campaign directed by and managed by the Supreme Council, There are a few things like some interviews on Qatar TV, Rayan TV, and others, some social media of campaigns and so on and so forth. In addition to that, like many other places, we also have our own application, mobile phone application that keeps track of cases, monitors people's mobility, and there are obviously these QR codes that would indicate whether a person is completely free or has been in contact or is in quarantine, or somebody who is really infected and is supposed to be completely quarantined. This application is mandatory. You can't go anywhere without this application, even if you want to go to the mosque or to the mall or to the anywhere to any restaurant to pick up something. You always have to show your ihtiraz application, and if you're not green, you're not allowed in. In addition to that, a massive campaign has been put together regarding PPEs, like masking. Everybody has to be masked out there, social distancing. The police have been very active in basically stopping people and asking them questions around their ihtiraz, around their mask, whether they have a mask on or not, and in a very, very nice way, in a very educative way, than non-authoritative but very firm but not authoritative. They basically are part of this education, public education, more than they are enforcing the law, but on the other hand, they are enforcing it in a more of an educative way. So a lot of that has been going on, and this has resulted in really, at the end of the day, flattening of the curve of the infected people. Now, so what is the strategic plan? What was the strategic plan? From the get-go, the Supreme Council, the Supreme National Command Center decided that they will, that Qatar will try to protect the tertiary hospitals as much as possible for the non-COVID patients. So all the COVID patients were triaged to the periphery, to more of a community hospitals out there in periphery, not in the heart of Doha. Early on, when we started to see some of these cases ramping up, these hospitals were, we had 3 hospitals that were barely open. They were brand new. They were just started to see patients. These were actually prepared for the FIFA Cup 2022. In preparation for that, these 3 big hospitals, these are general hospitals, that they were ready to be taking care of patients. However, with different levels of readiness. One of them, which is the main one that seen the COVID patients, is Hazm Barik General Hospital, HMGH. That one was the most ready amongst these 3 different hospitals, which is Misaid and Ras Lafan. So these 3 hospitals were designated as COVID hospitals. The main one was Hazm Barik General Hospital, which was designated as the main COVID hospital. That one initially had a capacity of 250 beds, but that was expanded within a couple of weeks to double that amount or even more. At one stage, and I'll go through that in a minute, at one stage when the curve started going up, the number of patients that needed ICU has gone up. Hazm Barik Hospital was completely transformed into ICUs, while Misaid and Ras Lafan hospitals were designated as secondary COVID hospitals. In addition to that, many other field hospitals were also erected and prepared. Some of the field hospitals seen a number of cases, and some of them they didn't get to see these patients, more patients, because the numbers started to be nicely controlled, and numbers started going down, and the curve was flattened. The other The other thing is that this is the Cuban hospital. The Cuban hospital is a small secondary slash tertiary hospital that is in the west part of Qatar, in Dukhan. That is fully equipped. It has the capacity to do ICU, but the population of that part of Qatar is very small. And that hospital was designated as the tertiary for COVID patients, the children and women with COVID positive cases that needed secondary or tertiary care, mainly tertiary care. And I'll go through that in a minute, that the majority of the surgical interventions that patients with surgery that needed to have surgical intervention and they were COVID positive, and if they are children or women, they were taken care of in the Cuban hospital. Now, the next level is the level of the general hospitals in town. So Al-Wakra is a city south of Doha, and Al-Khor is a city north of Doha. And then the private sector, which was also prepared to accept cases in case if we needed, if we move. So the move is from the community of these field hospitals down to Hazm Barik, the Said, Ras Lafan, and Cuban hospital, down to, if the cases increased, then we'll go to Al-Wakra, Al-Khor, and then the private sector will be also activated. Three major private hospitals were prepared in case if we needed. And then the last piece of the jigsaw was basically if we needed to go even further, if we had a lot more patients, then we go for the heart hospital, the National Cancer Center and Research, Hamad General Hospital, which is the main tertiary hospital in Qatar for the adults, and then Sidra would be the last to see any COVID patients. So there we go. From the get-go, the planning was that Sidra be as the last to be utilized for any COVID patient, any COVID positive patients. So this was planned. And then Sidra, as an organization, had to basically work with this plan and make sure that Sidra is a COVID-free hospital. Same was the Hamad General Hospital, National Cancer Center, Heart Center, but they were in that priority. Heart Center, National Cancer, Hamad General, and the last piece was Sidra, supposedly. So this was the plan. And these are the, and apologies for the blurriness in here. I cut it and pasted from a piece of communication. So this is at that point, this was the beginning of the crisis, where the bed capacity, the total bed capacity that was usable immediately for the COVID patient was 2,250 beds. While it was, as the plan of expanding the capacity of bed capacity, we could have gone up to 4,556 as the whole sector can provide that much ready beds. And as you can see, that Sidra Medicine in the initial space, or this is the last basically, was allocated to have 0 patients with COVID. Same thing goes for Aspetar, 0. With the private sector, 0. And again, Said, Ras Lafan, at the beginning, we didn't need them. The focus was basically on Hazm Barik General Hospital, then the CDC, which is another, obviously that's a communicable disease center, which saw CDC does not have ICU. So any patient who is in need of ICU would go to Hazm Barik. And then, so the CDC was utilized for cases that needed treatment, but they were not as sick to need ICU care, and that's the capacity of it. While as you can see that Hazm Barik could have gone all the way up to 621, and they did. Actually, Hazm Barik was the main hospital for COVID, and therefore they basically got all the, and they are the main hospital. The Cuban hospital to start with had a 72-bed capacity, but it can be expanded to 207, and so on. So as you can see, the capacity is well calculated and well planned. So how is this managed? How is this, how is this orchestrated? As I said, the National Command Center orchestrates the efforts at the country level, at different sectors level. In the hospitals, in the healthcare system, Hamad Medical Corporation had what they call SWIC, system-wide incident command center, and they had their own acronym. Basically, they had a mantra to keep themselves, excited about this and motivated about it. They are like supported by Almighty, wonderful performance, incredible plan, coordinated action, continuous. They had their own mantra. So the Hamad SWIC is the main, basically the main orchestrator of the move of the patients, of opening this hospital, closing that hospital, expanding, reshrinking. So that is where, and they have the full authority from the Minister of Health to take care of this, whatever is needed when it comes to taking decisions around healthcare in the COVID. So they had this delegated authority from the Minister of Health to take care of that. And Sidra participated in this fabric. So in Sidra, we had our own, so this is where we are now, our focus was basically, we are part of this national fabric, obviously, but how do we keep the designation as it was designated for us from the national strategy, that Sidra has to be clear from any COVID patient. So we had our own, obviously, command center that would meet on weekly basis or bi-weekly basis as needed with the status updates, with decisions, and the command center has the full authority. And we had a warden, obviously, and so the CMO is the chair of the command center. That would basically take any decision that is needed to keep Sidra where it is in the national fabric of the COVID-19 fading. So who brings in cases in? It's either patients, the parents of these children who are accompanying them, visitors, companions, or staff. And staff, it could be doctors, nurses, and other clinical support, or support, admin, or contractors. And we have a good number of contractors who basically come in the building for many things, including like cleaners, building maintenance, and so on and so forth. So how did we manage to make sure that none of these categories of human beings bring in any corona into this building? We had some measures. So all patients, these are some of the decisions that was taken and implemented. All patients, their companions or guardians, visitors, as well as the staff, are all screened prior to entry to this building, including temperature checks, obviously, answering a set of basic questions for contacts, fever, symptoms, whatever. And we will be all required to show that ihtiraz, that they are green, that their ihtiraz, that application is green. In addition, inpatients, companions, and guardians staying, and those are staying with the patients at this hospital, will be required to be COVID-free before their admission. So if a child needs to come in for whatever reason, whether secondary, tertiary procedure, radiology procedure, a visit, whatever, they stay in the ED until the test is negative. Then they are allowed in. If they are scheduled to get a procedure, let's say a bronchoscopy, they have to be tested negative a day before they are allowed to come into the building. Now, the other thing is that we absolutely minimize the number of companions for each inpatient staying in the hospital. Only one chosen companion per female. Obviously, we are women and children, so women who deliver or who have a gynecological procedure, they can have one companion with them. And if it's a child, then we have two guardians, adults like a mother and a father, or a sister and an aunt. I mean, couple of companions only. And the other thing is that once the companion comes in with the patient, they don't leave. So we don't allow out on pass. We don't allow so if the mother, and that has been a little bit of a problem, obviously. I mean, you are bringing in the mother in, and you are saying that you are staying with your child as long as the child is in the hospital. You can't go back and forth. So this obviously creates a lot of issues, and therefore we allow two guardians, so one can stay for a day or two, and then they leave, and the second one comes in, and then the first one cannot come back in. That's the point. So in order not to get them, they go to the community, they pick up the virus and come back. The other things that we have, in order to minimize the encounters, we have drive-through for our pharmacy. They call the pharmacy, they can come and pick up their prescriptions from the street. They don't come into the building. We have fully PPE'd staff that are standing on the drive-through and they're handing out the prescriptions that are pre-prepared. The other thing is that we also have agreement with our postal system in Qatar that they can also deliver to their homes. So the patient has the option of either calling in their prescription to be delivered at home, or they can come and pick it up from the drive-through with a specific timing. The other thing is that, so that is for the patient, for the companion. Then we have the people who are coming into the building, staff, doctors, nurses, contractors, admin, and so on. So a whole bunch of measures have been brought on board. Now, first thing, we classified the risks, definitions of risk levels. So we have patients who have high risk, or people with high risk, or people with low risk. And both of them, we're talking about contact. So if somebody, let's say a doctor or a nurse or a staff has contact in the community with a COVID patient, they're supposed to come back to work. Now, how do they come to work? So we have these categories of high level exposure, high risk exposure, or low level exposure. These are pretty standard definitions, basically. That if they are in contact with a patient that is proven to be positive for more than 15 minutes or 20 minutes, 15 minutes, and they have no PPE, that's a high risk. If they have PPE on, there is a social distance, that's a low risk, and so on and so forth. So these are pretty standard. And if they are high risk contact, we don't allow them in. Then we implement as per the occupational health guidelines, how do they stay home, and then they get tested, and so on and so forth. So the other thing is that our HR had to live up to this, because people can easily use all their vacation time if they are asked to sit at home because they have exposure for a couple of weeks, because they can't come back to work until they are negative, or the exposure is now very low risk, and the risk is gone. So therefore, we introduced, the organization introduced what we call COVID-19 special leave. Up to 2 weeks, they can have fully paid leave just because they are in quarantine. Then there is a very rigorous back to work protocol that was implemented based on occupational health recommendation, including testing, when to test and when to repeat the test if need be. And then very recently now, if you are positive, we also added the CT score. If it's less than 30 or above 30, if you're above 30, you're good. If you're below 30, then you're infectious. So therefore, you're kept at home for more time than the above 30. The other thing is that Sidra also has a very active mental health program that our mental health department has extended this service to all our staff with series of lecture. We are now on lecture number 17 or 18. Every week there is these sessions that are available online for people, live interaction with psychologists and psychiatrists. And we also extended our expertise in mental health, in child and adolescent mental health, to the community as well. And our mental health department is very active advocate of mental health during these crises for women and children. That's what we focus on. The other thing is that we also, as a children's hospital, we were very active in helping the community to understand how to handle kids in these type of crises. Again, from aspect of physical and mental health as well. The other thing is that so that is in general. So now talking about pediatric care during COVID crisis, how did we manage that? So we have patients, children with COVID and children without COVID. they can COVID positive or COVID negative, and they can have chronic or acute diseases, whether they are COVID positive or COVID negative. They can be treated for COVID or can be treated for other diseases coexisting with COVID. To start with, we wanted to make sure that with this lockdown and with this slowdown and with this, physical distancing and everything going into online and going, not having the chance to be seen by a healthcare provider would not affect the normal mandatory healthcare requirement for children. So the system has designated a number of primary healthcare centers that are basically COVID-free for immunization, normal child health monitoring, anticipatory guidance, weight growth and development follow-up, and so on and so forth. Non-acute sort of regular pediatric care, primary care was taken care of during, so they will not miss their immunizations and so on and so forth. The other thing is that we have a network of pediatric emergency centers in Qatar. They are spread through different, about 5 of them. These are walk-in, basically, acute illness management centers. The biggest one, which is the main pediatric emergency center in Qatar, which is called PAC Al-Sad. That's a very, very, very busy center. They see anywhere between 400 to 600,000 visits a year. Very busy as always. So the PAC Al-Sad was designated as COVID care center for pediatric care. Now, how do we do that? The center was split into 2 different physically separate tracks. The COVID track, which basically has a number, about 14 ICU sort of setup, and it's completely physically separate from the normal, quote unquote, normal pediatric emergency center as such. So the pediatric emergency continued doing their usual business with much lower volume, obviously, because patients are not coming for their colds and coughs anymore. They're staying at home because parents are worried to bring their kids to the pediatric emergency. Therefore, the number has decreased, obviously, that's natural. And then also the other track where these patients were basically any child with the cause of COVID positive would be admitted to those beds. And the turnover was very, very high, obviously, because majority of the kids with the COVID positive were either asymptomatic or mild asymptomatic. Now, at one stage when the number has started to ramp up like crazy, the non-asymptomatic kids were not admitted to the PAC Al-Sad, where they be put in the quarantine facilities with their parents, obviously. But those beds were kept for kids who needed to be treated, like they needed oxygen or they needed non-invasive ventilation or something like that. The Sidra Emergency Department, where basically where the triage is, where the gatekeeper for the patient is at Sidra Emergency Department. They have also a separate track that is physically separate from the normal track, and that track of COVID basically is a holding area for patients until they get their results out. So if somebody comes in with respiratory symptoms or whatever, they get their testing there, they stay there, they are monitored by ED physicians until the result comes out within, and then we have the rapid testing that they can get the result within an hour, while the normal testing takes up to 4 hours. So they will hold them there, and if they're COVID positive, if they need admission and they are COVID positive, then they go to PAC Al-Sad, to that track that I mentioned in a minute ago. While if they are COVID negative, they need to be admitted, they can get admitted to Sidra. And that is, so a COVID-free kid who needs admission for inpatient care will be admitted to Sidra. While a COVID positive kid who needs admission for either COVID treatment or other treatments, they will be admitted to PAC Al-Sad. As I said, the inpatient piece of pediatric care at Sidra obviously was kept completely COVID-free. In addition to that, our secondary inpatient at Hamad General Hospital was also kept COVID-free, and Al-Wakra Hospital, which has a pediatric bed population of about 20 beds, were also kept as much as possible COVID-free. So where are the COVID positive kids, the pediatric patients? In PAC Al-Sad, and in quarantine. And some of them were in CDC, the Center for Disease Control. But then all of these are taken care of by our staff, our pediatric residents and fellows. They are assigned. And that's another there is a protocol around the residents who are deployed to COVID areas. They cannot come back so they are deployed for like a month or two to a COVID area, like in PEC-LSAT. They cannot come back to Sidra or Hamad General Hospital without getting tested and being negative. And if they have a rotation over so the rotations were, and this is something I'm going to talk about at the end of this presentation, how did we manage the residencies and fellowships during this COVID crisis? So for the purpose of this particular station here, they cannot come back and work across the different organization, because if they are working in a COVID positive area, they are not allowed to come back to Sidra or to Hamad General Hospital, where they could potentially bring in COVID to the organization, to the facility. The other thing is that we started teleconference clinics and then virtual clinics that now is very active. And this was actually discovered to be a very good opportunity. Many patients actually prefer to have a virtual clinic than having a physical clinic. This was implemented mainly for follow-up patients. The new patients that needed to be seen, they were brought into the hospital, but obviously with the protocol of making sure that they are COVID negative. And that was the minority. The majority of patient population now, was handled virtually with virtual clinics that are fully documented and fully, legalized. So this way we avoid backlogs and having patients who have a lot of cancellation of their follow-up appointments with different services that are offered, etc. And as I said, the pharmacy was also transformed into more of a drive-through and home delivery. So now just a glance of tertiary care patients who have positive COVID. These are children now. I'm focused on children. So these are now kids who come in and they need tertiary care and they are COVID positive. Like if they have, like say, an appendix, or they have, they need to have a bronch, or they need to have a cardiac surgery. They are really sick and they need to be taken care of, and they are COVID positive. What do we do that? Because the service is supposed to be delivered by Sidra, while these patients are now COVID positive, and therefore, well, obviously the dilemma is you cannot bring them in to take care of them, but your expertise as Sidra staff is needed for these kids. What do? We used the other facilities. We used the Cuban hospital, which basically was designated as the surgical, pediatric and women's surgical and acute care facility. The other thing, if it was a cardiac patient, that patient would go to the heart center, which is basically an adult facility. Basically it's a heart center. So our cardiologists and cardiothoracic surgeons, cardiac surgeons will go there and operate on these kids and take care of them at the heart hospital. When they need ECMO or they need any ICU, they are taken care of at the Cuban hospital. And this is basically the algorithm that basically drives this flow. And in this algorithm, there are all the contact numbers, who to call, what to activate. And the purpose of this is basically once the patient is identified as in need for Sidra service, that Sidra service gets activated so that the team is mobilized to go for the patient, wherever the patient needs to be taken care of. And that is majority of the cases, as you can see at the bottom, is Cuban hospital, and then that's the heart hospital and Al Wakra hospital for burn. Our national burn center is in Al Wakra. So burn patients with COVID positive still need to be admitted to Al Wakra hospital, but taken care of by our plastic surgeons as well. So as you can see that what we try to do is that this building of Sidra is kept COVID free, while the service is mobilized where the patient needs it. So patients are not compromised and the building is kept COVID free as much as possible. And this is the latest now, the most recent algorithm and flow that was published by the SWIC that I mentioned earlier on from Hamad, and this is a system-wide where they are integrating now the the CT score as part of a triaging determination. And this is implementable for both adult and pediatrics. So moving on now to our academic agenda. We are an academic health system and we want to maintain our academic agenda during this crisis. And obviously you can't just take a complete break from your academic agenda when you are in crisis. Otherwise you tend to lose what you already built on, built over a number of years. If this crisis continues for a longer period of time, you might have a problem with maintaining the standards for your medical education and keeping up with your research deadlines and so on and so forth. So our medical education department here at Sidra takes care of undergraduate, graduate, continuous and interprofessional education. And the research center has human subject research and non-human subject research and lab-based. So how did we handle this? For medical education, obviously, we moved on to virtual classes. All the classes for these medical students, residents, fellows, they were all changed to virtual classes. And this was from the beginning. And as we moved on, we assessed the risk and the number of patients and so on. And we started now to open up some of these classes to become more of a physical, but with the appropriate social distancing office. For example, our morning report was reinstituted as a physical, but we are doing it now in the auditorium, where you can maintain a minimum of 2 meters between the two attendees, and so on. The other thing is that during the physical rounds, we managed to restructure the teams on the inpatient floors to be the bare minimum, while keeping the discussions more of a virtual discussion. So we have these team rooms, instead of having all of the team members be there in the team rooms or a bedside. Well, you know, only the resident who's taking care of the patient and the attending will go into the patient's room and then come out. Then in the meeting room where the case discussion is happening, there are virtual interactions with all the other team members, and so on and so forth. So minimizing the number of physical encounters. As I said, virtual morning reports, and then virtual handover. A lot of virtual stuff has been obviously implemented. When we have to come into physical contact, we use our PPEs and we have the social distance. And this almost became now the norm of the day. The other thing is that our students, residents, and fellows were involved in COVID-related activities that was managed centrally, as I said, by SWIC of Hamad. So obviously we are pediatric, mainly we have pediatric residents and pediatric fellows, and therefore most of the cases of adults are not relevant to us. The first priority was that we cover all the pediatric COVID patients, sure. In addition to that, we also have a small cadre of our residents who were put on standby to pitch in if need be. The other thing is that our newly graduating students from Cornell and from Qatar University were given the opportunity to work in the front line with the appropriate PPEs, obviously, and appropriate training and so on, to be exposed to these sort of education, immersed into these educational opportunities. So they were not, and in order not to be sidetracked by being used as service only, the educational goals and objectives were identified from the beginning. That you are going to see, let's say you are a student who just graduated and you are being deployed to, let's say, a field hospital. What are your educational goals? Apart from taking care of this and being part of this community of physicians and healthcare providers, there must be some sort of an educational goals for you to achieve. And that was monitored also by their mentors. So using this crisis also as an opportunity for learning was also kept in mind all the time. And we will continue learning as we move on. We have been also making sure that we're not just doing things out of our own, pockets. Basically, we always consulted with our accreditors, AAHCI as an example. Us at Sidra and our colleagues at Hamad, we have been in contact with AAHCI on almost weekly basis, making sure that they are content with what we are doing with the curriculum, with the residents, and so on. And the same thing for the medical school. The faculty, the medical school faculty were also kept in line with what we're doing at the hospital level. They were completely engaged with us whatever we're doing with the students. The other thing is that in addition to that, we have been keeping our governance also well informed and in charge of approving or disapproving what we are doing in the medical education. And our governance for graduate medical education, for example, is the Graduate Medical Education Committee that meets and basically monitors any modification in programs, any changes in their rotations, and so on and so forth, through the Medical Education Office, obviously. The other thing is that since this is a deviation from the regular curriculum for the residents and fellows, there has been a decision that we can extend, and this was in consultation and approval of the AAHCI, that we can extend the residency blocks and for the fellowship blocks, as long as we keep the educational merits and educational goals well monitored throughout this period of 1, 2, 3, up to 3 months. So far we have extended them 1 month, which is month of July. And we are studying it on weekly basis. Every week we meet and look at needs. Can we start, bringing them back into the regular curriculum or not, and so on. As far as research is concerned, again, Sidra is a very active research organization, and therefore a lot of research projects are ongoing, and they cannot be, and as we all know that the research deadlines are research deadlines, and you gotta deliver on those deadlines, whether it's regulatory deadlines or your experimental deadlines or your recruitment deadlines. I mean, all that in research, everything has to be done. If you're doing a clinical trial, it has to be done in a specific protocol that you cannot deviate from. Any deviation from the protocol has to be reported to IRB and so on. So what happened? Unfortunately, because of this distancing and in virtuals, all the human subject recruitment, physical recruitment, has been put on hold. But that has been also approved by our IRB, but also by our funders, the QNRF and so on. For example, QNRF was, QNRF has approved an extension or a hold up of the grants for about 3 months, 2 to 3 months. The grants are sort of put on hold, so you are not penalized for not being able to recruit subjects to your project, or not being able to perform to your milestones when it's out of your control because of the COVID situation. So QNRF, Qatar National Research Fund, and the Internal Research Fund has been also extended to cover this period as well. And same thing goes for our deadlines. Our in research you have deadlines, and these deadlines, some of them, majority of them, have been extended to accommodate this delay because of the COVID-19. The other thing is that the research personnel who are working in the labs, your techs, your admin people, all the techs, we had to minimize the number of physical existence of people, and therefore a lot of these experimental work that needed an actual technician or a research associate to come and work in the lab was put on hold, obviously. Now, how do you manage to be able to deliver and be innovative while you have this much limitation of the physical presence? The rotations, the PIs were basically planning this period, trying to collaborate, trying to prioritize and so on. That is pretty well understood. Any PI would understand that they would manage their time and their deliverables according to these emergencies and emergent situations. But that said, Sidra still, alhamdulillah, has managed to contribute significantly to the global COVID fighting by basically coming up with rapid testing, new rapid testing that was readily available, made available for everybody to use. And that was something that is part of our vision. We are non-for-profit, and we want to make sure that whatever we come up with is in the best interest of humanities, the best interest of academics, in the best interest of our patients, and the world. So therefore, this test, which was recognized by our organization, AAHCI, this test is a rapid test that basically decreases the turnaround significantly, but also is cheaper, readily available, and labs can make their own. So we made available, our research branch has made this available on our website for people to basically reproduce if they are interested in. So the other thing is that in order to keep ourselves well informed of how are we performing, what are we doing, are we really, is this just theory or we are actually performing, and what is the impact on the COVID existence in the building. So Sidra has a very active microbiology, virology lab, obviously, like many other places. And we keep track, our lab keeps track of the number of tests, and we get reports on weekly basis that summarizes the whole week of testing, positivity, categories, and so on. And this gets shared with a group of leaders and a group of clinicians who are in the decision-making seat, but also are stakeholders when it comes to how to use this data to better improve patient care and keep the designation of COVID-free building going. So the test is, the COVID testing is performed. This is the regular, this is not the rapid test. The rapid test can be done anytime. And those are for determination of whether the patient comes in or not come in, and so on. But the regular testing takes up to 4 hours, and it's done 3 times a day during the working days and 2 times a day during the weekend. The results are typically published 4 hours after the test and released and informed to the clinicians. And obviously, if any of this is positive, patient will be immediately triaged to, and these are not our inpatient, because all these inpatients have been tested already negative. We're talking about emergency room patients. Or occupational health, or women. So women who want to come in and deliver, or who come in for a gynecological procedure, and so on. These are some of the examples of the reports that we get. These are released on weekly basis, and these are the number of tests that's been done. And as you can see, so the blue is the children, tests in children. Red is our occupational health, so basically that's staff. OB patients are the little ones, and family members, where we now here before this period, we were not allowing family members to come in. And this is where we allowed family members to be tested, and the number of testing for family members have picked up, obviously. And these are the positivities and negativities, and as you can see, it's categorized into how many children with positive tests, how many OB patients have we, how many OC health, and how many family members. And we keep getting all these so we can keep track of it. Our numbers are small, as you can see. The percent of positivity overall is less than 2%. In pediatrics, and less than about 2% or less in the family members, while OC health, which is basically our staff, were out in the community all the time and back and forth, they are about 7 to 8% positivity. And those positive, obviously, they don't come back to work. They are staying at home, they are quarantined, they are managed according to the national management scheme. And this is our average positivity versus intermediate testing. So we know indeterminate testing, so we know how sensitive our testing is, and we keep track of that too. Now, again, test volume versus positivity, negativity in the dailies. So the test at 14 days, at 20 days, at 30 days, and we keep track of that as well. These are all reported on weekly basis to us. If any question, there is always a microbiologist that we can ask more specific questions if we are interested. So what did we learn? And I'm about to close this one. You ought to have a national command center, no question about it. Otherwise, it becomes very piecemeal and chaotic at the country level. We, as Sidra, are part of the whole fabric, and we cannot be working in silo. Working in silo creates a lot of conflicts and a lot of contradictions and major flaws in the system. So if you are working, not being part of the fabric, you could be part of a Swiss cheese sort of the loophole will show up. You ought to have a local command system in the hospital itself. That's what we had, obviously, to manage all the different little pieces that are basically designated to us. And we need to make sure that work goes on. Our vision and mission is not affected. Our operation is not majorly affected. We're not like all of a sudden frozen or all of a sudden regressing backward. So that way you need a local command center to keep monitoring and keep commanding the different pieces of the jigsaw. Testing strategy is very important. We test everybody. We do a lot of testing. We don't wait for patients to be symptomatic to test them. We test everybody. And that way we are able to anticipate who can be isolated, who should not be allowed in the building, who should be isolated at home, who should be sent to the... So this testing and a lot of testing is really helpful. And that, I think, was the main key why we were able to flatten. The testing will give you the substrate to take the right decisions. If you are not testing, you can't find these patients, obviously. And then the other thing is that it is strict adherence to measures. There is no leniency when it comes to the measures of preventing the spread of this virus. In this building, for example, even if you are the CEO, you ought to show your ihtiraz, and if you didn't, you're not allowed in that building. And there was some instances where some of the quote-unquote senior staff comes in and they would say, you know, I was tested yesterday. I know, why are you testing me? They were reported to the HR, and HR took action against them, although they were senior, really senior, some of them C-suite. But obviously that was early on when people were thinking that, you know what? Maybe we're just doing this for the others. The point is, this is for everybody, because we are all prone to carry this virus into this building, and therefore we all have to abide by this. So strict adherence to measures is critical. Education, education, education. And this is the key. I think forcing people is something, educating them so they embrace these measures, they accept it, they become ambassadors for the measures instead of becoming rebellions. System flexibility. What do I mean by system flexibility? There are essences behind all these measures. These measures are not out of blue. Every measure has a reason. So why do we do ihtiraz? Why do we do screening, temperature? Why do we have, these all have reasons. So if the reason is taken care of, we shouldn't be so rigid around, now let's say I'm gonna check your temperature, and if it's negative, if it's high once, you're out. No, actually, as a matter of fact, you want to make sure that they don't have a fever, that the fever is indicating that they might be carrying the virus. So that's the essence. You don't forget about it. So if the flexibility piece is that, okay, I'm going to repeat this temperature. And if it's still high, I'm going to ask further question, and I'm going to send them to the occupational health. So that's the flexibility piece. You don't want to create conflicts at the point of screening. Keep governance tight and well-informed. What do I mean by that? So the governance of whatever you are doing, whether it's medical education, research, operations, whatever governance you have, every piece has a governance, and there is also a central governance through the C-suite. They need to be well-informed, and they need to, this governance has to be tight, meaning although you can delegate pieces of the decision-making, but you can't let it completely go away without tight monitoring, because otherwise you can potentially create these silos of decision-making that might not be consistent with the centralized decision. So that piece needs to be kept in mind. Plan your academic agenda properly and proactively. As I just mentioned that, you know, we got to be flexible, but also we want to make sure that we use these crises as opportunities, not as I'm hit by a bus, I don't know what to do with it. Oh, okay, you know what, I can't let the residents do this, or I let them go because of the, so you don't panic. If leadership starts panicking, everything falls apart. All the academic activities can be managed, even the CME CPD. Now in CME CPD, our accreditors, AMA and QCHP, would say, you know, it has to be physical, it has to be interactive, it has to be whatever. All those, you can start negotiating with the accreditors how to make a virtual activity accreditable and a CME awardable. Things like that. You got to plan those things. So I think this crisis has taught us a lot around how to manage our academic activities. The other thing is that we always, we don't want to be lost into procedures. And that's my last point. You don't want to be lost into procedures, but respect them. Meaning, why accreditors want you to do certain standard? You need to understand that standard, where is it coming from, and why that standard was implemented or required, and then you can negotiate around the essence of that, instead of saying, oh, okay, you know what, it has to be physically interactive, therefore I cannot give CME for this. Well, that is rigidity. That is, you're not just respecting the measure, you are actually becoming a slave, enslaved to the measure instead of being respectful to it. So what I'm advising that we respect the measures, we understand it, we negotiate, we tease out, and make sure the essence is not lost. That is my take in any measure, including medical education, IRB, you know, just name it. Any measure has an essence behind it. We go with the essence and work with the accreditors to make sure that it is custom made for the current unusual situation. I think that's it for me for now. I'm going to stop here, and I'll be happy to answer any questions or comments if there is any. Thank you.
Thank you, Dr. Janahi. That was excellent. To really appreciate your time and effort for the presentation. I'm going to go ahead and open the floor for discussion. If you have any question, you can either insert it in the Q&A box, or you can type it in the chat box, or you can raise your hand and I can unmute you. We already have one question from Dr. Ghassan. Quite impressive, especially in Qatar, with one of the highest incidences of COVID worldwide. What about cases that turned out to be or become positive after admission and their contacts, especially that the initial PCR test is 75 to 85% sensitive?
Correct. So thank you for the question. First of all, the comment on why we have this very high level of we feel that this is a reflection of our testing strategy, more than any sort of a defect in a measure of avoiding spread and all that. So we are, although we have one of the highest incidents, but we have maybe the second lowest mortality rate in the world. But also our curve has been very nicely flattened. Part of the deal is that the response and the planning of the healthcare sector to these numbers, or to the whole crisis, made sure that we avoid any real catastrophes. So we are happy with that so far, alhamdulillah. The other question around what would happen to somebody who is in the hospital, admitted because it was negative and they are being taken care of, and now the test or repeat test is showing positive. So that patient will immediately go into, and they are typically isolated. So we are capable in Sidra, we are capable of doing the full isolation for COVID. We have all the facilities to do that. They get isolated immediately. The staff will get tested, all the staff, all the contact, staff, parents, everybody gets tested immediately. And they go into the algorithm, the national algorithm. So if they are a child, if this is a child with positive now, they go into a different facility. They move into PECLSAT or a Cuban hospital as per their health need. So that's one thing. The contact will be dealt with accordingly. So if any of the contact is positive, they go into the algorithm of positive COVID. If the contact is still a contact, they also go into isolation at home or at quarantine, wherever they belong, as per the algorithm. So they don't become our problem. It becomes a part of the national plan. I hope that answers the question.